Hello, everyone, and welcome to our module on the cerebellum. So the cerebellum is sometimes called the little brain because it sort of looks like its own small brain that's hanging off the brainstem. It's found right behind the pons. This is the pons right here, right next to the fourth ventricle shown right here. And the cerebellum, as we'll see in this video, is very important for posture and balance, also muscle tone, and also coordinating movements. So there are a number of different ways to describe the anatomy of the cerebellum. I'll start by focusing on this image over here on the right. So there's a structure down the midline of the cerebellum that's called the vermis. This will be important later when we talk about the clinical features of lesions involving the vermis. And then outside the vermis, you can find cerebellar hemispheres on either side, one here and one here. You can then also divide the hemispheres into a posterior lobe and an anterior lobe separated by the primary fissure. And then if you look at this image on the left side of the screen and you look at the other side of the cerebellum, you can once again see the vermis in the midline. But then on the other side of the cerebellum, you can see these two structures here. These are each called a flocculus or a flocculi together. And then in between the flocculi, you find this nodule here. And so this entire structure right here is sometimes collectively called the flocculonodular lobe. And here's another picture just to make this more clear. So this is the flocculonodular lobe. It includes the flocculus here and another one over here and this nodulus structure in the middle. The bundles of nerves that carry signals into and out of the cerebellum are called peduncles. So let's talk about those now. There are two peduncles that bring information into the cerebellum. Those two peduncles are the inferior cerebellar peduncle and the middle cerebellar peduncle. And then there's one peduncle that carries information out of the cerebellum, and that's the superior cerebellar peduncle. The inferior cerebellar peduncle is the major pathway into the cerebellum from the spinal cord. It has lots of different tracts that provide nerve fibers to this peduncle. I've listed the important ones right here. And importantly, what the cerebellum is receiving is ipsilateral spinal cord information on proprioception. So the right side of the cerebellum is going to receive information about proprioception on the right side of the body, and that information comes from the spinal cord via the inferior cerebellar peduncle. The middle cerebellar peduncle connects to the pons. It has fibers within it that are called pontocerebellar tract fibers. They come from the contralateral pons. And so these are the two inputs to the cerebellum, the middle and inferior cerebellar peduncles. The inferior and middle cerebellar peduncles are made up of fibers called climbing and mossy fibers. This is a description of the axons that enter the cerebellum through those two peduncles. The climbing fibers are named climbing fibers because of the way they look under the microscope. They all come from the inferior olivary nucleus, which is found in the brainstem. The mossy fibers are the other type of fibers. They come from all other cerebellar inputs. And all of these axons, whether they are climbing fiber axons or mossy fiber axons, and whether they're coming in via the inferior or middle cerebellar peduncle, they're all going to synapse on cells within the cerebellum called Purkinje cells or deep nuclei. And so as I said before, the major pathway out of the cerebellum is via the superior cerebellar peduncle. This peduncle is made up of axons coming from the deep cerebellar nuclei, which we'll talk about in a second. So what this means is that all the outputs of the cerebellum originate from the deep nuclei, and they exit the cerebellum via the superior cerebellar peduncle. And from there, those axons go to the red nucleus, which can be found in the midbrain, and also to the thalamus. Okay, so now let's talk about the Purkinje cells in a little bit more detail. These are neurons of the cerebellum. They receive lots of inputs, but they project to one place, the deep nuclei of the cerebellum, which we'll talk about in a second. These neurons are inhibitory. They release GABA, which is an inhibitory neurotransmitter, to influence the deep nuclei and to modify the deep nuclei signals leaving the cerebellum. And one special thing to know about the Purkinje cells is that they're highly vulnerable to hypoxia. So for example, when patients suffer a cardiac arrest, there's global central nervous system hypoxia. But some cell types are more vulnerable to cell death in that setting than other cell types. The Purkinje cells are a cell type that's often damaged in patients who have global hypoxia, and that's because they're uniquely susceptible to a lack of oxygen. And then the deep nuclei, as we've already discussed, are cerebellar neurons that project out of the cerebellum. If you look at this drawing on the slide here, these are the deep nuclei right here. The most lateral of the deep nuclei are these structures right here called the dentate nucleus. They project to the thalamus, specifically to the contralateral VA and VL nuclei of the thalamus, which I talk about in other videos. And incidentally, this is the same region of the thalamus that the basal ganglia interacts with. So much like the basal ganglia influences movement by interacting with this region of the thalamus, the cerebellum does the same thing. Inside the dentate nucleus, more toward the midline of the cerebellum, you find these two deep nuclei here. They're called the interposed nuclei. They include the emboliform nucleus and the globose nucleus. And both of these send projections to the contralateral red nucleus in the brainstem. And then finally, the most medial, the most close to the midline of all the deep nuclei is the fastigial nucleus shown here, and it sends projections to vestibular nuclei and also the reticular formation in the brainstem. Okay, so here's a summary of the cerebellar circuitry that you should be familiar with. So the two inputs to the cerebellum are nerve bundles called the middle peduncle and the inferior peduncle. They're made up of climbing fibers and mossy fibers. They are going to synapse on the Purkinje cells and the deep nuclei. The Purkinje cells can influence the deep nuclei using the inhibitory neurotransmitter GABA, and then the deep nuclei send projections out of the cerebellum via the superior cerebellar peduncle. Let's talk about which side of the cerebellum influences movement on which side of the body. So in general, the cerebellum mostly controls the ipsilateral or same side of the body. The reason for this is because cerebellar fibers cross to the contralateral cortex, but then the contralateral cortex has fibers that cross again and influence the contralateral arm and legs. So you get two crossings, and as a result, the right side of the cerebellum is going to control the right side of the body and vice versa. The inputs to the cerebellum are also ipsilateral, so information about right side of the body proprioception goes to the right cerebellum. And so what all this means is that lesions will cause ipsilateral findings. So if you have a left cerebellar lesion, you will get left cerebellar symptoms, and we'll talk about what those are in a minute. In contrast, if you have a right cerebellar lesion, you will get right-sided symptoms. Okay, so now we're going to talk about the clinical features of cerebellar disease. And first, you need to understand a broad principle. And that principle is the following. Lateral lesions in the cerebellum tend to affect the extremities, meaning the arms and legs. So lesions of the cerebellar hemispheres, which are the outside regions of the cerebellum, or lesions of the dentate nucleus, which is the most lateral of the deep nuclei, these lesions in these areas tend to affect the extremities. In contrast, midline lesions of the cerebellum tend to affect the trunk and the eyes. So for example, if you have a lesion of the vermis, which is located right here in the midline, or if you have a lesion of the more medial deep nuclei, like the emboliform, globus, or fastigial nuclei, or if you have a lesion of the flocculonodular lobe, which is considered a midline structure, all of these things will lead to problems involving the trunk and eyes. So what are some of the clinical features you can see in patients who have lateral cerebellar lesions? These are the lesions, as we said, that affect the extremities. Well, first of all, patients can develop an intention tremor. This means that their hand does not shake at rest, but when they try to move it towards a specific target, it will start to tremble and they can't get the hand to the target. This is different from Parkinson's disease, where you get a resting tremor that's present even at rest. It's not the case with cerebellar disease. To see the tremor, you have to ask the patient to try and reach out and touch something, and that's when their hand will start to shake. That's an intention tremor. In lateral cerebellar lesions, you can also see falls toward the injured side. That's because of discoordination of the leg. They can't get their foot to land properly on the floor, and therefore they fall to the injured side. And then finally, in lateral cerebellar lesions, you can see dyssynergia. This is a general term for a lack of coordinated limb activity, so let's talk about this now. So some of the findings you can see in patients with dyssynergia are listed on this slide. First of all, intention tremor is evidence of dyssynergia. So is dysmetria. This refers to loss of movement coordination. It basically means the patient overshoots the intended position of the hand. You assess this clinically by doing what's known as finger-to-nose testing. So you ask the patient to touch their nose with their finger and then extend their hand and touch your finger, which you're holding in front of their face, and then go back and forth from your finger to their nose. And if the patient has dysmetria, they will keep missing your finger or missing their nose. Another manifestation of dyssynergia is called dysdiadochokinesia. This refers to an inability to make movements exhibiting a rapid change of motion. So the classic way to demonstrate this is to ask the patient to put their hand of one hand in the palm of the other hand and then flip it over back and forth multiple times. If they have dysdiadochokinesia, then they won't be able to do this. They will struggle to be able to flip their hand back and forth in the palm of one hand. Okay, so that's lateral lesions. Now let's talk about what happens in patients who have central cerebellar lesions. As I mentioned before, these lesions tend to affect the trunk, the midline of the body, and also the eyes. So the vermis is a midline region of the cerebellum, and when you have lesions here, patients can develop truncal ataxia. This means that they can't hold the trunk of their body straight, and it tends to fall to one side. This can cause them to be unable to stand independently without help. Also, when they're sitting and they need to hold their trunk up straight, they will often fall over to one side. And you can see damage to the vermis leading to these symptoms in many different situations, but you should be aware that vermis degeneration is classically associated with chronic long-standing alcohol use. And then the flocculonodular lobe is another midline cerebellar structure. It connects to the vestibular nuclei, and so if you know this, it's an easy way to remember that lesions of the flocculonodular lobe lead to vestibular symptoms, things like nystagmus, vertigo, nausea, and vomiting. Ataxia or loss of balance is a classic clinical feature of cerebellar disease, but it can happen for a couple of different reasons. Sometimes it happens because of limb ataxia. Basically, patients who have clumsy legs and can't get their foot to go where they want it to go, this can lead to ataxia. And this can be caused by a lateral lesion. Remember, lateral lesions affect the extremities, like the arms and the legs. And you can also get ataxia for the reason we were talking about in the last slide, truncal ataxia. So when you can't hold your trunk or your midline up straight, this can lead to loss of balance. These patients have an unstable posture overall. They typically adopt a wide-based gait. This is to try and keep them balanced when they're standing. They can fall from one side to the other. And truncal ataxia, as I've already mentioned a few times, comes from a midline cerebellar lesion, often a lesion of the vermis or the flocculonodular lobe. There's a test that I talk about in a number of videos called the Romberg test that can be done to assess patients with ataxia. But you should be aware that this is a test for sensory, not cerebellar ataxia. Let me explain what I mean by this. So the Romberg test evaluates patients for a loss of proprioception. When patients can't feel where their limbs and their body is in space, they compensate through vision. So the Romberg test assesses for sensory ataxia like this by asking the patient to put their feet together and close their eyes, just like shown in the top panel here. If the patient loses their balance or falls when they close their eyes, this is a positive Romberg test. And this means that they have a sensory ataxia and they have lost proprioceptive information coming into their spinal cord. When patients have cerebellar ataxia, they will have loss of balance even with their eyes open. And that's a key point to understand. When the eyes are open, if your cerebellum is not working, you will still have ataxia. It's only if you have a sensory ataxia where you can't sense proprioceptive information through your spinal cord that the Romberg test will be positive with the eyes closed, but when the eyes open, the patient will be able to maintain their balance. Okay, let's talk about some other clinical features of central cerebellar lesions. I've already touched upon some of these, but let's go into them in a little bit more detail. So nystagmus, which is a rhythmic oscillation of the eyes that I talk about in detail in the video on the vestibular system, you can see nystagmus in patients who have midline cerebellar lesions. Classically, it comes from lesions of the flocculonodular lobe because this lobe sends projections to the vestibular nuclei and they control eye movements. The nystagmus that you see in patients with cerebellar disease is upbeat, downbeat, or vertical nystagmus, or gaze-evoked nystagmus, meaning that the direction of the nystagmus changes when the patient changes the direction they are looking in. Other forms of nystagmus like horizontal, left-right nystagmus, or torsional nystagmus, those are usually seen in patients who have peripheral vestibular dysfunction, not central vestibular dysfunction like you see in cerebellar disease. And then nausea, vomiting, and vertigo, this can also be seen with midline lesions, especially the flocculonodular lobe, and that's once again because this lobe of the cerebellum connects to the vestibular system. A couple of additional cerebellar symptoms I've listed on this slide. Hypotonia refers to loss of muscle resistance to passive manipulation. So you can test this clinically by asking the patient to resist as you push or pull their arm, like what's shown in this picture here. Patients with cerebellar disease have loose-jointed, floppy joints. And this comes from lateral lesions. This is another manifestation of the limb problems of lateral cerebellar lesions. And then scanning speech is a type of speech you can see with cerebellar disease. This refers to irregular speech. So normally a person might be able to smoothly say, "How are you doing?" Someone with scanning speech will pause and stop and start and say, "How are you doing?" like I've listed here. This comes from midline lesions of the cerebellum. The vermis in particular controls a lot of the speech muscles, and that's what gets disrupted and leads to scanning speech. And so here's a summary of the different symptoms and clinical features of cerebellar disease, depending upon whether the lesion is lateral or midline. All these are things I've gone through in the last couple slides. I won't repeat them here, but this table is super high yield for your board exams. They're often going to ask you whether lesions are midline or lateral. Okay, so I'll finish this video by talking about some clinical disorders that can lead to cerebellar dysfunction, and I'll start by talking about cerebellar strokes. I won't go into a lot of detail about these strokes because I talk about them in other videos, but I just want to highlight the blood supply to the cerebellum, which is shown in this image on the screen here. So this is the cerebellum right here. It gets some blood flow from the superior cerebellar artery. It also gets blood flow from the posterior inferior cerebellar artery and the anterior inferior cerebellar artery. And it also gets some blood supply from deep branches of the basilar artery. So strokes involving any of these vessels can lead to ischemia of the cerebellum. Usually when this happens, there are other clinical features of brainstem strokes, things like motor weakness and sensory loss and so forth. There are tumors that can affect the cerebellum, including these three right here. I go through all of these in detail in the video on central nervous system tumors. And then there are examples of congenital disease that can affect the cerebellum, things like Dandy-Walker malformations and Chiari malformations. And these I also go through in detail in another video. And then the final set of disorders I'll talk about in this video are the hereditary ataxias. There are many, many of these. They all are associated with motor incoordination related to problems in the cerebellum. And the two hereditary ataxias that you should be familiar with as a medical student are ataxia telangiectasia and Friedreich's ataxia. So let's talk about these things now. So ataxia telangiectasia is an autosomal recessive disorder, and it leads to ataxia or loss of balance because of atrophy of the cerebellum. This usually begins in the first year of life. I'll talk more about this in a second. It's called ataxia telangiectasia because it's also associated with telangiectasias. These are dilations of capillary vessels, either on the skin or sometimes on the conjunctiva of the eyes. And then beyond this, there's an immunosuppressive effect of this disorder. So patients have repeated sinus and respiratory infections. This is from immunodeficiency. And then finally, people with this condition are very sensitive to radiation. So they have a high risk of malignancy because radiation-induced DNA damage can lead to tumors. So the clinical features of ataxia telangiectasia are summarized on this slide. First of all, most children are healthy for the first year of life. They start to walk at a normal age, but then they have very slow development of their walking thereafter. And then progressively, they get more and more motor coordination problems. And by 10 years of age, most children with this disorder are in wheelchairs because of ataxia and inability to hold their balance. In addition, they have recurrent sinus and respiratory infections, and they have telangiectasias on the skin. This is a picture of some telangiectasias around the ear in a patient with this disorder. And then finally, as I just said in the last slide, there's a high risk of cancer, especially lymphomas and acute leukemias like ALL. And one of the things this means clinically is that you want to limit exposures to x-rays for these children because it can trigger a malignancy very easily. So things like CT scans, chest x-rays, you want to limit those in children who have ataxia telangiectasia. The cause of this disorder is DNA hypersensitivity to ionizing radiation. This disorder is caused by a defective ATM gene, which you find in chromosome 11. ATM stands for ataxia telangiectasia mutated gene, appropriately named when it was discovered to be the cause of this condition. This gene has a gene product that repairs double-stranded DNA breaks. Specifically, the product of this gene helps with non-homologous end joining, which is something I talk about in detail in videos in the cell biology section. It's a way that cells repair double-stranded DNA breaks, and this non-homologous end joining process is disrupted in children who have ataxia telangiectasia. So when they have this mutation, they're unable to repair DNA mutations that are caused by ionizing radiation. And unfortunately, there's no definitive treatment for this condition, and overall it carries a poor prognosis. And then the final thing to be familiar with around ataxia telangiectasia is that this disorder is associated with a number of classic lab abnormalities. So let's go through these now. First of all, alpha-fetoprotein levels are almost always elevated in children with this condition. This is the most consistent lab finding. The reason for this is incompletely understood, and this isn't diagnostic of the disorder because AFP levels are elevated in lots of other conditions as well, but definitely a finding of increased AFP is something you expect in a child who has this disorder. The T cell count is classically low in children who have ataxia telangiectasia, so they have T cell lymphopenia. And then finally, they tend to have so-called abnormalities of humoral immunity, and by this I mean low antibody levels. Especially IgG levels and IgG, they tend to be low in children with this condition. And this is just another indicator of the immunodeficiency associated with ataxia telangiectasia. And then the second hereditary ataxia we'll talk about in this video is Friedreich's ataxia, another autosomal recessive condition. The cause of Friedreich's ataxia is a mutation of the frataxin gene found on chromosome 9. You need the product of this gene for normal mitochondrial function. What happens in Friedreich's ataxia is that this gene picks up an increased number of trinucleotide GAA repeats. I talk about trinucleotide repeat genetic disorders in their own video in the genetics section, but these are disorders where there are normally a certain number of repeats of a specific base combination like GAA, but in a mutated gene, there are extra copies of these repeats. And the more repeats the frataxin gene picks up, the worse the prognosis of patients who have Friedreich's ataxia. These extra repeats lead to decreased frataxin level. And as I said, frataxin is a mitochondrial protein. There are high levels in the brain, the heart, and also the pancreas. And these are the organs that are going to have dysfunction in this disorder because when there's abnormal frataxin production from the frataxin gene, this leads to mitochondrial dysfunction in all these areas of the body here. The clinical features of Friedreich's ataxia usually begin in adolescence, somewhere around the teenage years to the early 20s. And the initial symptoms are motor symptoms related to cerebellar and spinal cord degeneration. So there can be degeneration of all these regions shown right here. Spinocerebellar tract degeneration can lead to ataxia and dysarthria, which is difficulty speaking. The spinal cord dorsal or posterior columns can be affected. This can lead to loss of position and vibration sense. You can lose the corticospinal tracts. This can lead to upper motor neuron spastic paralysis. And you can also have damage to the dorsal root ganglia. This can lead to loss of deep tendon reflexes. Some other features of Friedreich's ataxia include kyphoscoliosis, which is an abnormal curvature of the spine. That's what's shown in this image on the slide here. This is sometimes the presenting symptom before other neurologic symptoms have come on. And then children with Friedreich's ataxia can develop foot abnormalities, sometimes referred to as pes cavus. This means a high arch of the foot that doesn't flatten with weight bearing. It's shown in this picture on the slide here. People with Friedreich's ataxia can also develop hammer toes, which is also shown in this picture. And these findings aren't specific to Friedreich's ataxia. You can see these findings in the foot in other neuromuscular diseases where patients have abnormal sensation in the lower extremities. In particular, Charcot-Marie tooth, which is a condition I talk about in other videos, also can lead to these same foot abnormalities shown here. And then finally, because Friedreich's ataxia can affect the pancreas and the heart, it can lead to cardiomyopathy and also diabetes. So people who have this disorder often develop insulin resistance, impaired insulin release, and beta cell dysfunction, and all of this can lead to diabetes. And then the classic complication of this disorder in the heart is hypertrophic cardiomyopathy. This is a picture of it on the screen here. This left ventricle is very, very thick, much more thicker than you would expect in a normal person. And this can lead to arrhythmias, and this is a common cause of death. Even though this is a neurologic condition, the common cause of death is problems related to the heart and hypertrophic cardiomyopathy. And that concludes our video on the cerebellum.